Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. High-tech tools dominate medicine, but are doctors missing basic information if they don't listen to, look at, and touch the patient? This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Abraham Verghese is on a crusade to restore the physical exam to its role in diagnosis. When physicians order expensive images and pay more attention to the computer than the patient, they risk losing the human connection.
Are the incentives in American medicine interfering with good care?
We are reimbursed in America generously for doing things to patients as opposed to for patients.
Coming up on the People's Pharmacy, find out what doctors could learn from Sherlock Holmes and why diagnosis might improve when patients talk and doctors listen.
First, this news.
In the People's Pharmacy health headlines, commonly prescribed antidepressants called SSRIs are linked to fractures in older women. These drugs have become popular to treat the menopausal symptoms of hot flashes and night sweats. That's because they do not carry the same risks of breast cancer and heart disease as hormone replacement therapy. Paroxetine, sold originally as Paxil, is now prescribed as Brisdel to ease symptoms of menopause. But other SSRI-type drugs are being prescribed off-label for the same purpose.
Epidemiologists have compared women taking these non-hormonal drugs to women taking heartburn medicines such as cimetidine or omeprazole. All of the women in the study were between 40 and 64 and were not depressed. There were 137,000 who started taking SSRIs. They included citalopram, known as Celexa, escitalopram, known as Lexapro, fluoxetine, better known as Prozac, and sertraline, prescribed under the brand name Zoloft. More than 236,000 women were taking the heartburn medicines. Those on antidepressants suffered 76% more fractures during the first year and 67% more fractures over a 5-year period. Since women's risk of fracture begins to rise dramatically at menopause, it's worrisome to think many women might be taking a drug that could increase this danger even more. This also raises questions about the overall safety of SSRI-type drugs for people being treated for depression.
A study in the New England Journal of Medicine suggests that a diabetes drug called liraglutide can be used to help people lose weight. Originally developed to control blood sugar under the name Victoza, liraglutide is now also prescribed under the name Saxenda for weight loss. In this trial, a high dose of liraglutide helped people lose roughly 12 pounds more over the course of a year than those on placebo. People who discontinued the liraglutide injections after a year regained about 6 pounds in the next 3 months, so it is possible that the drug will be needed indefinitely to maintain weight loss. Side effects included digestive tract upset, gallstones, and pancreatitis. A higher incidence of breast cancer was also noted. The side effects and the cost, at approximately $1,000 a month, mean that patients will have to consider carefully whether the benefits are worth the risks.
There's growing evidence that diet impacts the risk of developing diabetes. Long-term data from more than 100,000 health professionals show that increasing meat consumption raises the risk for type 2 diabetes. The investigators analyzed detailed reports of food consumption from the volunteers at the beginning of the study and every 4 years thereafter. Those who increased their consumption of processed meat products such as bacon, hot dogs, sausages, or deli meats saw their risk of diabetes rise over 4 years. Unprocessed meat consumption also had an impact, around 30% elevated risk over such a time span. People who lowered their meat intake by about half a serving a day had a slight decline over the course of the 20-year study. The researchers are not quite sure what it is about red meat that might be the culprit. Some suggest saturated fat, while others blame it on sodium, preservatives, heme iron, or just extra calories.
One of the complications of excess weight is that it contributes to chronic inflammation. Higher levels of inflammatory markers such as interleukin-6 are linked to diabetes and some cancers. Investigators at the Fred Hutchinson Cancer Research Center studied the effect of adding vitamin D to a weight loss program on interleukin-6 levels. The study included over 200 healthy, overweight, postmenopausal women. Their levels of circulating vitamin D were below the recommended amount of 32 nanograms per ml. The women were assigned to do 45 minutes of moderate to vigorous exercise 5 days a week. Half received 2,000 IUs of vitamin D daily, while the other half were randomly assigned to take placebo. At the end of the study, markers of inflammation were lower in both groups. Exercise and weight loss do make a difference on inflammation. Those who lost 5 to 10% of their baseline weight and also took vitamin D had the biggest drop in interleukin-6 levels. The authors conclude that vitamin D can augment the benefit of weight loss on chronic inflammation. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Diagnosis is the cornerstone of medical treatment. If the diagnosis is mistaken or in doubt, the treatment may be worthless or, worse, counterproductive. Doctors have a lot of tools to use in making a diagnosis, but do they sometimes overlook the most basic?
Dr. Abraham Verghese is eager to draw attention to the value of the physical exam and the history. He is Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University School of Medicine. His acclaimed books include My Own Country, The Tennis Partner, and a novel, Cutting for Stone.
Welcome to the People's Pharmacy, Dr. Verghese.
Thank you so much. Thanks for having me.
It's wonderful to have you back on the People's Pharmacy, Dr. Verghese. And I guess I'd like to start our interview with you by asking you about Sherlock Holmes and Dr. Arthur Conan Doyle. Why are you such a fan?
Well, I think he's a great writer to begin with, but I think the thing that draws me is that he was inspired to develop the character of Sherlock Holmes because of a teacher of his in medical school. Conan Doyle was a physician, and one of his teachers was Joseph Bell. And Bell was a legendary clinician, extraordinary, but honestly probably not that extraordinary in the sense that both on this and that side of the Atlantic there were clinicians who were so adept at reading the body for clues of disease and making associations, but Bell was one of the best. And Sherlock Holmes Conan Doyle many years later, writing about Bell, described some incidents, and you can sort of project from those clinical encounters into the writing of Conan Doyle, where he clearly took advantage of those astute powers of observation. For example, if I may give you an example, a lady comes into the clinic and the students are all around Bell, and she says, "Good morning," and Bell says, "What sort of crossing did you have on the ferry from Burnt Island? And what did you do with the other child? And did you take the shortcut through the botanical gardens? And are you still working at the linoleum factory?" All this before she's even opened her mouth. And then he goes on to point to the students the subtle clues that enabled him to say all these things about her before she'd even offered anything. And I love that story. My students love that story too. I think it inspires them and it reminds them why they came to medicine.
And how did he know that she worked in a linoleum factory?
Well, she had a peculiar dermatitis on the fingers of her right hand, which was unique to the linoleum factory workers in Burnt Island. And she had red clay on the sole of her shoes, and such clay was not to be found within 100 miles of Edinburgh. And so she must have taken a shortcut through the botanical gardens, which was the quickest way to the clinic. And her accent was a Fife accent, and therefore he speculated that she took the ferry over from Burnt Island, which is the nearest crossing from Fife. And finally she was carrying a coat in her hand that was too small for the child who was with her. So she had started the journey with 2 children and dropped one along the way. And mind you, we can make these observations every day. It's just that I think strangely, as a society, we are not being as observant as we might be.
Well, it's easy to see how Conan Doyle constructed the character of Sherlock Holmes from this teacher of his, Dr. Bell. It's a little harder to see how a modern-day doctor would follow in the footsteps, as it were, of Dr. Bell. Does that still happen?
Well, I think it should happen. I mean, if you think about it, it's only in the late 1700s, 1800s that we began to be able to look into the body, so to speak, during life. First was the development of percussion, thumping on the body and establishing that the lungs sound hollow, and when they're filled with fluid, they sound dull. And shortly thereafter came the stethoscope, and then came sort of legions of observations that allowed us to pick up the expression of disease on the exterior of the body or by lack of function, and correlate that, with what was going on inside. And I mean, even to this day, disease still presents that way. The fact that we have other ways of diagnosing disease and maybe, more sensitive ways of diagnosing disease doesn't change the fact that most often disease manifests on the body. I mean, 100% of dermatology pretty much is recognizing what you see in front of you. But just like that, there are so many disease conditions that manifest on the body or manifest in some sort of dysfunction that allow you to make a very astute diagnosis. And why not take advantage of that? Why subject the patient to, as happens all the time, radiation and contrast and, surgical misadventure, when the diagnosis was really evident and would have been evident to a well-trained clinician, but wasn't to someone who got sloppy and relied only on the test they were ordering.
We are told, Dr. Verghese, that misdiagnosis is quite common and has been common for decades, that the rate may be as high as 10 or 15%, meaning that over 100,000 people die every year in hospitals because they were misdiagnosed, and if they had been diagnosed correctly, might have gotten alternative treatment that might have saved the day. We all admire Sir Arthur Conan Doyle and his character Sherlock Holmes because his astute powers of observation allowed him to sometimes come up with amazing revelations that his sidekick, Dr. Watson, was always amazed at. It seems that today doctors are in such a hurry. There's such time pressure and such reliance on cutting-edge technology that the idea of actually sitting down with a patient and observing, the lower lip, the quiver of the jaw, some muscles that might be tensed, the kinds of things that Sherlock Holmes presumably would have been aware of, there just isn't time for that anymore.
Well, I think you're right, although I don't think it's solely a question of time. I actually think it's a little more complicated than that. I mean, one of the things that has happened with the abundance of technology and the ability to, confirm things so much more, properly, in a sense, by imaging. One of the things that has happened is as technology has become ascendant, our faith in our own simple skills of examining the patient have seemed to go down. And I think it's, I joke, but I only half joke, that if you come to one of our hospitals missing a limb, no one will believe you till they get a CAT scan, MRI, and orthopedic consult. It's almost as though we don't believe what our senses tell us anymore, and we've become so reliant on the test as opposed to common sense and our own judgment. But I think even more than that is the fact that so much of what we're doing is driven by reimbursement. I mean, the fact is that if you order tests, especially in the emergency room, if you order a CAT scan, MRI, angiogram, everything you order is actually a moneymaker for the hospital. There's lots of incentives to order the tests. And, there's some pressure from defensive medicine for you to, not get sued, so you better order the test. And I often think that if we didn't have those financial incentives, I don't think we'd be ordering these tests willy-nilly. So that's part of the reason. I think it's not just time pressure. It's sort of it's become easier to order a test than to take the time to, examine someone, and you don't have much faith in your own examination. The other factor I think is quite critical is that we in the United States have abandoned a high-stakes clinical exam at the end of training. I mean, you would be shocked to hear this, but it's the truth that when you finish medical school, you're tested with a multiple choice test. You're tested with a clinical skills exam, which really doesn't test the kind of clinical skills we're talking about. It's much more about your ability to get rapport with the patient and to extract the story and, point to the right body part in your examination. But we're not really checking to see whether people can find a big liver or a big spleen or pick up a rash. And, I think that in the absence of a high-stakes clinical exam, people just haven't taken the trouble to train well in these areas, whereas in countries like Britain and Canada, where they still have a high-stakes exam and you won't get your degree if you don't pass those exams. I think there's a lot more investment in those countries in teaching clinical skills. And for some reason in America, we abandoned the high-stakes clinical exam, and we abandoned it some time ago, partly because it was so difficult to keep it even, to keep it fair, make it less subjective. But I mean, even with its subjectivity, it was a fairly good hurdle that people could have aimed to cross. So the analogy for me is that you're a drunk and you lost your keys in the dark, and so you go search under the light. And so here we are, we're doing multiple choice questions because they're standardizable, they're well reproducible, you can come up with all kinds of fancy curves around them, and so the statisticians, the quantitative mafia, as I call them, have put that in place, but it doesn't get at the qualities that you and I are just talking about, the ability to, make simple diagnoses and spare the patient painful and expensive and sometimes dangerous testing and misadventure that results from testing that never needed to be done in the first place.
You are listening to Dr. Abraham Verghese. He is the Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University's School of Medicine. He's written My Own Country, A Doctor's Story, The Tennis Partner, and a novel, Cutting for Stone.
Terry, I'm disappointed in what Dr. Verghese said about the quantitative mafia. These are the people who, I guess, certify that a medical student is ready to become a doctor. And the idea that they are relying so heavily on standardized tests rather than those old-fashioned clinical skills that used to be considered so important 20 or 30 years ago.
Well, it is true that trying to figure out what someone hears when they listen through a stethoscope, what they feel when they mush on your belly, that's very hard to standardize.
No, but clinical skills are so critical, and I think we all do have to believe our senses. This reimbursement incentive system that relies on testing and gets rewarded for it, that's just a little scary.
Well, we do need to take a short break. When we come back, we'll talk more with Dr. Verghese about the importance of the ritual of the physical exam. Are doctors in training shortchanged by an emphasis on advanced imaging and other high-tech tests over touching and listening to the patient?
Is medicine too obsessed with treating the numbers, like cholesterol or blood pressure, and doing things to patients rather than for patients?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible by Red X Industries, makers of Utter Cream and Utterly Smooth Extra Care Cream enriched with urea to moisturize dry, cracked skin. 800-345-7339. online at uttercream.com.
And by We Patients, where you can learn from others about possible triggers and potential treatments for your headaches or migraines. Online at wepatients.com.
If you'd like to order a CD of this show, you can call 800-732-2334. This is show number 881. That number again, 800-732-2334. Or find it online at peoplespharmacy.com.
Today we're talking about the art of medicine and the value of human touch in the diagnostic process.
We're talking today with Dr. Abraham Verghese. He is Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University School of Medicine. Dr. Verghese has several books, including My Own Country, A Doctor's Story, The Tennis Partner, and his novel Cutting for Stone. Dr. Verghese, as an anthropologist myself, I wonder if there aren't aspects of the physical exam which really perform the function of a ritual, a way for two people to connect with each other and kind of understand what their roles are in a process that should be a transformation. Would you comment on that, please?
Yeah, I'd be happy to. I've actually written about that with an anthropologist colleague of mine here at Stanford and a folklorist at Bowling Green University, pointing out that, the process of examining a patient has all the trappings of a ritual. You go into a special space. The furniture in the room is like nothing anywhere else. One participant wears a symbolic white coat, the other one wears a paper gown which is soon stripped off. There is the use of, Latinate terms that are potent and mysterious. And then there are rituals that the physician engages in that are mysterious to the patient. And we, I think, in Western medicine have lost sight of how important that ritual is. Rituals are all about transformation. We engage in these rituals, I think, not this ritual, but we engage in rituals like marriage and so on to signal a transformation, a change. And I think that this event of one individual going to another, telling them things that they would not tell their rabbi or preacher, and then incredibly disrobing and allowing touch, which in any other context would be assault, I think that this is a ritual of exceeding importance. And so, quite apart from the diagnostic yield of, examining someone who's saying, I hurt here, you're also in the process of examining them. You're sort of confirming this location of their pain by touching it. You are, you're sort of not saying this resides in an image in a computer somewhere. This resides on your persona. You're sort of confirming their personhood, and you're confirming the validity of their complaint. So as the years go on, I've been more and more impressed with how the ritual matters to patients. Living here in the Bay Area, we see all kinds of ethnic communities, that I've never encountered before, Hmong and Tongans and, Samoans. And it's impressive to me how many people have so many different opinions about medicine, treatment, but they all seem to share the belief that if you're going to put them in a room and put them in a paper gown, that you're going to examine them. And if you shortchange that process, if you just stick your stethoscope on top of the gown or give a half-assed prod of the belly, patients recognize that you have just shortchanged the ritual. And conversely, if you do the ritual well, then I think you earn something that is hard to define, but I would put it as you have cemented the patient-physician relationship. Here at Stanford, where we have very complicated patients with, all sorts of tertiary care problems, somebody with their second liver transplant and some brain abscess, and, there sometimes are 10 different services consulting on that patient. And, it's not unusual for the patient to see 30 doctors troop in and out at different times of the day. And I've been impressed how now and then a patient will ask for me to clarify some point that I may have brought up. And they can't remember my name, but they'll often say, the one who examined me, And not to say that I'm the only one who examines them, but I make a practice of it with my students present. If I'm seeing the patient for the first time, even though I've heard the physical from my house staff and they've been seen in the emergency room, I have to examine the patient to validate this for myself. And it's unusual enough. We've become so dependent on the computer and driven by the computer that it's almost as though the real patient resides in the computer. And every time you examine the patient, it validates something for them that's quite memorable. And I think it's memorable to our trainees as well.
Dr. Verghese, can you share the story of the patient who you knew who had breast cancer and was scheduled to go to one of the country's most prestigious research institutes for the latest and greatest treatment, and then surprisingly ended up back in your hospital in your neighborhood being treated by just a regular oncologist?
Yeah, I think it was an anecdote that changed a bit of the course of my practice, because it made me realize how critical patient perception was towards about what we were doing. And you could have the greatest care in the world, but if the patient doesn't buy into what you're delivering, it doesn't really matter. So this was a friend actually who had a breast lump, had her lumpectomy locally, and then had the resources and the means to research the best cancer center in the world. And you know, there are many that compete for that title, and went to this place, and it was actually excellent. They took great care of her. They, knew her tumor inside out. They coordinated her visits. But she said reluctantly, when I pushed her, she said, they didn't really pay much attention to my breast. They didn't examine my breast carefully. And you and I could argue that they did not need to examine her breast. They had it scanned inside out. They knew it at a molecular level. They knew it at the, receptor level. But the point is, to her, it greatly mattered. The fact that no one examined her breast thoroughly the way she expected them to spoke to her to a kind of inattentiveness that she was not going to abide. Whereas going to her local oncologist, every single time she went to see this person, they would examine the breast, the axillary tail of the breast. They would dig deep above her collarbone looking for supraclavicular lymph nodes. And there was something about that practice and that ritual that spoke to her of a system that would, abide with her, would not give up, would be thorough. And I came away from that anecdote thinking, wow, we've only worried about our end of things. And I must hasten to tell you that I'm not a Luddite. I love technology. I'm practicing in one of the, most incredible hospitals in the world with cutting-edge technology. But, technology is not going to reassure your patient. There still remains, and I think it's a timeless thing that'll always be there. The patient-physician relationship is unchanged through eternity and will remain so. At some level, patients are coming to you with a subtext, whether they recognize it or not. And the subtext is, Daddy, Mommy, help me, tell me it's going to be all right.
Exactly.
Obviously, they can't quite say that, but I think that's operative even when I go to see a physician. And it's in the manner, it's in the development of the patient-physician relationship, it's in the ritual, it's in the caring, it's in the attentiveness that we then convey to the patient, yes, I will abide with you, I will take care of you, I will never let you down. And you can't do that by ticking off boxes on a computer, or you can't do it any other way.
You've suggested, Dr. Verghese, that the patient feels shortchanged if the physical exam is hurried or inadequate in some way. But I'm wondering if medical students and residents aren't being shortchanged in their curriculum, if they're really learning how to do a physical exam of the sort that you're describing.
Yeah, and by the way, I should just say parenthetically that the routine physical, the annual physical, we know doesn't particularly have a high yield. So I'm not so much talking about that kind of physical as I am someone's coming in doubled over with pain. And before you send them for the CAT scan, to me, it's always worthwhile to get a good history and examine them, because you might stumble right onto what's causing this. And then you ask a better question of the test that you order. You're not just saying, what in the world is going on, let me get the test. You're saying, I know this looks very much like pancreatitis, and I want to know, is there also a gallstone? Questions like that. But to come back to your question, I think our medical students are actually fairly well trained in how to examine the patient in the first 2 years of medical school. And then they come to the wards in the third year, and they suddenly realize that the currency on the wards does not revolve around examining the patient, that no one's carrying the instruments that we taught them so carefully to use, like ophthalmoscopes and reflex hammers, and that everything revolves around the computer. In fact, I've coined the term the eye patient to speak about that virtual entity in the computer, and how the patient in the bed has become almost an icon for the real patient who's in the computer. And the eye patient is getting wonderful care all across America. The real patient often wonders, well, where is everyone? When are they coming to explain things to me? What's going on? And I think medical students are surprised to find that that's how the world works. And they quickly adjust. They become very adept at the computer. And very much like the peers who are around them and their superiors, they also begin to just neglect the physical exam. Now, we at Stanford have taken some pains to reverse that trend. There's a hunger out there for this kind of training, and I find that very reassuring. It would be very hard to do this if there wasn't a sense on the students' part, on the trainees' part, that there's something that I don't have that somehow physicians of another generation seem to have in spades. And I want that, and that's great.
Dr. Verghese, I'm thinking about this hypothetical eye patient you've been talking about, and I'm wondering if focusing on that electronic representation of the patient really leads some doctors to treat the numbers rather than the patient. We sometimes hear from patients who say, well, my doctor is really pleased with the way that this cholesterol-lowering drug has gotten my cholesterol down to, below his target level, but I feel terrible, and I can't exercise, and I can barely get out to socialize, and we're thinking to ourselves, somehow this doesn't all match up.
Yeah, I think it's a fine line. Again, I'm not a Luddite, and I love the medical record for what it can now do. I mean, for some patients, there's so many data points that, if you tried to look at this on a chart, it would be next to impossible. And the computer does some wonderful things. In fact, I think there'll come a time when it will trend things for us on individual patients in a way that our human brain probably can't quite encompass. And, just to play the devil's advocate, I mean, you can have a patient feeling entirely well, and yet their creatinine, which is a measure of their kidney function, is creeping up. And if you don't do something, they'll be on dialysis. But you might know that for 2 years before they ever feel anything. So in some ways, modern medicine is about watching the numbers and, as you point out, watching the numbers without checking in with the patient and without balancing that with the patient's own reports is terribly important. I tell the house staff all the time that, when a patient has an acute complaint, your first instinct should be to really go and get a great history of what they're feeling and then examine them carefully. And, sometimes you'll find something right then and there that explains it. And it's almost easier to order a test than to go and really examine the patient, figure out what might be going on before you order the test. And I think that too much of that is going on, where we order tests as a proxy for our presence in a funny way.
Dr. Verghese, you talk about taking a history. And of course, doing that means listening. But we've been told that physicians have been trained or have watched their mentors interrupt patients after, in some cases, as little as 14 seconds. And many patients actually feel pressured that they have to get the whole story out as fast as possible because the doctor's going to be interrupted by a phone call or somebody's going to come into the room. And so sometimes the ability to share your story without interruption, that's not very easy. And many physicians these days are actually sitting at a computer console or a laptop, putting notes into the computer as you talk so that there's no actual eye contact during the interview.
Yeah, I think there's great truth to that. I think there's a challenge to use an electronic medical record with the patient present, and especially if you're turned towards the computer and not to the patient, it's hard to leave the patient feeling that you're being attentive. And I think we're all struggling with that balance. But the one good thing that the computer does is, I have a young doctor taking care of me, and she is much more adept at the computer than I am, and so manages to enter data with the same ease with which you and I would scribble in a notebook while the patient was talking. I often take the chart in and make notes while the patient tells me things. So she manages to do that with some ease. But I think what the computer offers is the opportunity to share the screen and show you the images and show you the trends and the graphs. And I think that's actually been a good trend, because in many ways, otherwise the system pulls you in, tests are ordered, the images you never really get to see, they belong somewhere else. And these are in fact your images. And I think the computer has that ability, the opportunity for us to actually get deeper into our healthcare data. But the danger, as you point out, is that we're sort of pointing away from them. I think time is a bigger and bigger issue, especially in primary care. I mean, the average primary care practitioner has to see something like 18 to 25 patients a day to pay the overhead. And, if we don't value primary care and we don't reimburse it at that rate, that's the kind of care we're going to get, where people have barely time to listen. And more of my best colleagues are going into concierge medicine, and they do it with some sense of sadness, because they don't really like this idea of charging, a fixed number of patients a large fee. But what they do get is to practice medicine the way they'd like to practice, which is to be able to sit there and listen to that patient at great length and make house calls and make telephone calls, because they have a small population of patients and they can spend as much time as they like. I think if primary care were reimbursed at a different rate, things would radically change, and there are definitely movements in that direction. So right now, we are reimbursed in America generously for doing things to patients as opposed to for patients. If you can do something to a patient, stick a needle, stick something into them, you will make a lot of money. And if you are going to do something for the patient, especially I'm thinking of my aging parents, the kind of care they need from a physician takes time. It takes time to listen to them, takes time to examine them. God bless the physicians who do that, but they are unsung heroes, because they're not paid at the same rate as when we call in somebody to do something very specific. And they get a lot of money for that. And honestly, I don't think that people's abilities are that different. If you're in Scandinavia, whether you're a thoracic surgeon or an internist, you're getting the same pay scale. That is really how it should be. Not that we should socialize medicine, but we should take away the kind of financial incentives that drive us into, having 17 CAT scans in a town of, 30,000 and having people falling over each other to make money because there's so many incentives to do that.
You're listening to Dr. Abraham Verghese. He's the Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University School of Medicine. He's written My Own Country, A Doctor's Story, The Tennis Partner, and a novel, Cutting for Stone.
It's time for us to take a short break. When we come back, we'll talk more with Dr. Verghese about how doctors use their senses to make a diagnosis and the dangers of anchoring a decision before all the facts are clear.
Can we encourage doctors and patients to tolerate uncertainty until they get the true diagnosis? Are there questions a patient can ask to help reduce diagnostic errors?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339. The website is uttercream.com.
And by We Patients, where you can learn from others about possible triggers and potential treatments for your headaches or migraines. Online at wepatients.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 881. That number again, 800-732-2334, or on the web at peoplespharmacy.com.
We're talking with Dr. Abraham Verghese about the art of the physical exam He's Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University School of Medicine.
Dr. Verghese, several years ago we talked with Dr. Catherine DeAngelis, who at the time was the executive editor of the Journal of the American Medical Association. She described an interchange with an eye doctor, a young ophthalmologist who was doing her eye exam, and she asked the doctor for some Kleenex because the eye drops that he had put in her eye were starting to drip down her face. And he reached for the Kleenex and he passed them behind him with his arm, just sort of trying to give it to her without even looking at her or paying her much attention. Dr. DeAngelis is a rather short woman, but a very powerful one, and she grabbed his hand, she said, in an iron grip, and she said, "Young man, turn around and look at me." And I think what she was trying to say is, you can't just ignore me. You really do have to pay attention. And I think she was using that as a metaphor for the interaction between physicians and patients today.
Yeah, I certainly hear a lot of complaints from patients about the very thing you were talking about, the attention being focused on the computer. But I also hear some great stories. I think there's, even in these difficult times, even with the time pressures and the advent of technology, I'm impressed by some of the demographic changes in medicine that I think bode very well. For example, more than 50% of our class of medical students are women. And I think that's because the kind of people who might have come to medicine to make a lot of money are now heading to venture capital and to other things. And I think we have people whose hearts are, not that other people's hearts weren't in the right place, but more and more I think people come to medicine for the right reasons because they can tell that, the heydays of making a lot of money are probably diminishing. And they really care about their patients, and they also are very computer literate, brought up in this era. So I think we're seeing this interesting thing where I feel like I'm learning a lot from watching them because they are adapting to the kind of stresses and changes that I complain about, and yet they're managing to convey their care. Training has changed too. We have different work hours and all kinds of rules that have been enforced that keep the physician from, the trainee from being in the hospital for days on end, which was the case when we were training. And I think it's not just more humane, it really allows them to focus more on the patient rather than focus more on themselves and their lack of sleep and their sort of need to take care of themselves. So as much as we list all the things that are wrong with medicine, there's a lot of things that are quite extraordinary, particularly the whole revolution in molecular medicine, the new therapeutics, the new diagnostics for cancer. But as you point out, as we've been talking about, you can still never alter, in my mind, the primacy of the patient-physician relationship. I met someone who's a very thoughtful businessman, extraordinarily wealthy, and very good at sort of analyzing data. And he made the statement to me that, I really don't need a physician to take care of my diabetes. I've researched this. I've learned so much about it. I know more than most of my physicians. And I thought, that may well be true. You just haven't reached a point where, you need the solace of having a companion on this journey that you're taking. And I think as much as sophisticated as we get about disease, we will still need the partnership of a physician to care for us.
Dr. Verghese, you talk about the body as text, and it has to be inspected and palpated and percussed. Even the scent in the room is important. And Terry, when you were growing up, there was a family practice physician who actually came to the house, and the first thing she did was smell the room.
Well, in fact, I think she was a pediatrician. I was a little kid at the time, so I'm not absolutely certain of the specialty. But this doctor had been trained in Germany before the Second World War, and she could distinguish the scent of measles from the scent of mumps. I mean, she did use her olfactory sense as part of the examination, as part of the, to give her diagnostic clues. And I have heard you today talking about the physician using his or her hands and eyes and ears as part of the physical exam. Is the nose also a part of this process?
Yeah, I think it is. I don't want to make too much of it, but I mean, certainly in the early years, people claimed that, the scent of freshly plucked feathers was what measles was like, and mumps was like freshly baked bread. And I don't think we actually see enough of those diseases anymore to have that kind of astuteness. But I don't doubt that these were true. But we have common odors that we encounter all the time. You walk into the room of someone who's having diabetic ketoacidosis, and you get this fruity odor, kind of like Wrigley's Tutti Frutti gum, that sort of a scent in the room. Or someone with liver failure, you get this ammoniacal, mousy odor. Or someone with kidney failure, you have a uremic odor, almost like urine. So there are clearly distinct odors that go with certain diseases, and I don't doubt that they help us come to a diagnosis, but I don't think we actually sniff to make the diagnosis. It's just part of the whole package. Sometimes you walk into a room and you encounter this really putrid, foul-smelling odor, and you're dealing with an abscess of some sort, a lung abscess or something. Sometimes you get a sickly, sweet, grape-like odor, and that's often infection with a bug called Pseudomonas. So I think we definitely use that, but we probably don't use it as much as people did 100 years ago when, to see measles, to see mumps, to see typhoid, to see tuberculosis was common, and there was no treatment. So you not only saw them, you saw them run their full course. So they probably distinguish things that we don't have the practice to do anymore.
Dr. Verghese, the human traits of humility and fallibility and uncertainty are not always valued or modeled by medical mentors. And as a result, you end up with misdiagnosis. I know that Dr. Jerry Grootman, who has written about this, talks about something called anchoring, whereby the physician or the resident or even the medical student in training throws the anchor down when they hear certain key elements of the patient's story and may disregard some things that don't fit. So again, playing Sherlock Holmes, maybe jumping to a conclusion too quickly. How do we encourage uncertainty when it exists so that the patient and the physician can interact in a way to get to the true diagnosis?
Well, I think you've said it well. It's we're all full of inherent biases. We're often biased towards the last patient we saw that was memorable, and we start making that diagnosis too often. Somebody said that clinical experience is the ability to make the same mistake with increasing frequency and mounting confidence. That the word experience is sometimes quite loaded. I think, you have to keep going back to re-examine the data. I think anytime a patient doesn't sort of progress the way you're expecting, or you don't quite know what's going on, I think you've got to go back and reconfirm the history and go back and examine them again. A new clue might have popped up. Go back and sort of look at all the lab stuff that has come out and see if you haven't overlooked some sort of clue or trend. It's a very fertile area of clinical interest and research, the whole area of diagnostic thinking and diagnostic error. I'm more interested in the sort of more obvious kind of error that's not picked up when we talk about medical mistakes. There's been this great literature that's come about medical mistakes and how every day it's the equivalent of a jumbo jet crashing, the number of people who are subjected to medical misadventure. But there's another kind of error which only physicians recognize, and we are doing this study where we're collecting anecdotes from physicians of situations in which someone was subjected to a test or something obvious was overlooked that by all rights should have been picked up on a history and physical. And, we're picking up hundreds of examples, and it's the kind of error that only another physician would recognize, that someone came in with abdominal pain, for example, and had a very obvious outbreak of shingles on their abdomen, and the abdominal pain was really the shingles. But since no one looked carefully, no one really saw the rash, instead of which the person got a CAT scan with contrast, and this consult, that consult, until finally one of the consultants stumbles onto this. There are legions of examples like that, and that's not an error of bias, or that's not an error of, a cognitive error. That's simply an error of sloppiness in this era of abundance of technology, where we're more inclined to order something than to take a look at the offending part, which I think is the least you can do. Just take a look where it hurts.
Dr. Verghese, are there any questions that a patient should ask a physician in order to reduce the likelihood of a diagnostic disaster?
Well, it's difficult for me to sort of say that in general the patient should ask this question, but I think it's fair to ask this physician how they've come about the diagnosis, whatever it is, especially if it's one that's consequential. And I think it's fair to ask, well, do I need this test? What about if I have some other test? For example, my father has some prostate issues, and sort of routinely they wanted to get this and that, and they wanted to get a CT to look at his kidneys. And my father said, I'm 80-something, and I really don't want to have this CT test. What is it going to tell you that you can't tell me by some other means? And they backed down. They said, well, fair enough, we don't have to have that. And I think there are many instances where protocol might ask us to get something. It's ideal to get that thing, but especially if the patient expresses a strong preference, I don't think we should feel like we have to get these things.
Dr. Verghese, you have spent your career dealing with patients with some very complicated medical problems. For example, for many years you have dealt with patients with HIV/AIDS. You've also interacted with patients who have chronic fatigue syndrome. And in both cases, having a physician who listened the way you did is a great gift. I mean, I can't think of any greater gift one person can give to another than listening. Can you share with us briefly what it was like in those parts of your career when you might not be able to cure the patient, you might not even be able to make a huge difference in their treatment, but just being there and caring for them made a huge difference in their lives?
Yeah, I'll be happy to. I don't want to overstate this. I mean, I'm one of a legion of physicians of that era who all experienced, the lesson of HIV. A very painful time, because I remember talking on your show, with a friend of mine from Chapel Hill on the show as well. And, we were all in that era where there was no good treatment for HIV, and all we could offer was, in a sense, ourselves. And I think we all learned, that there was so much to that in offering ourselves. I remember one time waiting to see a patient in my clinic and then getting a call that he wasn't coming to the clinic because he was too weak to come. He wasn't sick enough to put in the hospital, but he was too weak to physically come to the clinic. And besides, there was nothing I could do. This disease had no treatment, and he was gradually dwindling. It didn't sit well with me, and I decided to go see him in his house, a considerable drive from where I was, more for my own sake than anything else. And when I got there, to my amazement, my visit had a profound effect on the family. It helped the family come to terms with this impending death. It helped the patient feel as though I had not abandoned him. And I remember walking away from that feeling, wow, this is what the horse and buggy doctor of 100 years ago, or 200 years ago, whenever that was, did so effectively. They were unable to cure, but they could heal. And the example I use with my medical students, I say, imagine that you're, go back from this lecture today and find that your door's been bust open in your apartment, and you go inside and all your belongings are strewn around, and you find your computer's missing, your cash is missing, your jewelry's missing. You'll be devastated. You would not only have suffered a loss of stuff, physical loss, but you also would also feel a sense of spiritual violation. Someone violated your sacred space. And if the police come by an hour later and say, we caught the person who did this, here's all your stuff back, at that moment you will be cured, but you would not be healed. Your sense of violation would be so powerful that you might choose to leave that apartment and move somewhere else. So I use that analogy to say that all illness has both a physical sense of loss, which we in Western medicine are very good at fixing for the most part. But it also always has a sense of spiritual violation, which we in Western medicine have not been as good at fixing of late. And I think that we're recognizing, especially in chronic disease, especially in fatal illness, that even when you can't cure, you can heal, by which I mean the presence, the caring, conveys something that we all as human beings need. Francis Peabody said many, many years ago that the secret of the care of the patient is in caring for the patient. And I don't think that'll ever change.
Dr. Abraham Verghese, thank you ever so much for talking with us on the People's Pharmacy today.
Thank you for having me. Wonderful show.
You've been listening to Dr. Abraham Verghese. He is the Senior Associate Chair and Professor for the Theory and Practice of Medicine at Stanford University School of Medicine. His books are My Own Country, A Doctor's Story, The Tennis Partner, and his novel, Cutting for Stone.
Lynn Siegel produced today's show. Robin Copley, Russ Henry, and Al Wadarsky engineer the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red-X Industries, makers of Utterly Smooth Extra Care 20, with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
And by We Patients, where you can learn from others about possible triggers and potential treatments for your headaches or migraines. Online at WePatients.com.
Next week, we'll be discussing how promising new therapies can go sour.
If you'd like to order a CD of today's show, you can call 800-732-2334. Today's show is number 881. That number again, 800-732-2334. Or you can find it at our website, peoplespharmacy.com.
On our site, you can share your thoughts about today's show or check out our books, guides, and products. Find answers to your questions about common ailments, prescription medications, herbs, and home remedies.
You might also sign up for our free online newsletter or the free podcast of the show. You can hear more of our extended conversation with Dr. Verghese by subscribing to the podcast. It'll be delivered straight to your computer so you never miss another People's Pharmacy program again. You can also share it with a friend or your physician. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks so much for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.